So the endocrine system. It's responsible for sexual differentiation in utero, stimulates growth and development during childhood and adolescence, stimulates development of the reproductive system in both sexes, and is responsible for puberty. Puberty is the sexual maturation lasting about 4.5 years. Anybody know what the average onset is for girls? 9. How about boys? 11. It occurs when the gonads secrete increased amounts of sex hormones, estrogen and testosterone. The hypothalamus produces increased amounts of gonadotropin-releasing hormone, and this stimulates the anterior pituitary gland to secrete LH and FSH. In boys, the LH stimulates testosterone production and FSH stimulates sperm. In girls, LH and FSH stimulate the development and maturation of ova and ovulation. These hormones in turn stimulate gonads to secrete more sex hormones, resulting in development of primary and secondary sex characteristics. So pituitary gland disorders, specifically growth hormone deficiency. It prevents somatic growth throughout the body, or this is hypopituitarism. It's most common, the most common cause is idiopathic, so the most common cause is we don't know the cause of it. It can also be caused from tumors or trauma. Or if the child's had surgery of some sort up in that area, it can be hereditary. Assessment would be if the child is short, obviously. And this is usually seen by age 2. Diagnosis is done from lab work, CTs and MRIs, and growth measurements. These kiddos get injections of growth hormones. They're sub-Q injections 6 to 7 days a week until the bone matures, which is usually after puberty. Diabetes. A lot of this is going to be reviewed, I'm sure, from your med-surg. And I know you all can tell me what the difference is in between type 1 and type 2. What is it? Very good. Type 1 is insulin dependent, so their body does not make insulin. It's an autoimmune disease. So in type 1, the body's immune system attacks the beta cells in the pancreas that make insulin. Insulin is an essential for carbohydrate metabolism. So children with this type of diabetes must take insulin. Type 2 diabetes is a separate disease from type 1 diabetes. It is characterized by diminished insulin secretion and is not an autoimmune disease. What do you think the first symptoms of type 1 diabetes are? There are 3 P's, so polydipsia, which is extreme thirst, polyuria, which is a lot of urination, and this often begins with bedwetting, polyphagia, which is unusual hunger. And these are results of hyperglycemia, so your 3 P's are signs of hyperglycemia. Polyphagia, unusual hunger. It's diagnosed with a blood sugar, or a fasting blood sugar, 8-hour fasting blood glucose level greater than 126 or more, random blood glucose of 200 or more with classic signs of diabetes, oral glucose tolerance test of 200 or more in 2 hours, you want to teach them to self-monitor their blood glucose levels. What type of education do you think you want to provide? Diet. What else? Exercise. Okay. Sub-Q injections of insulin. What else? Foot care. They might have decreased sensation, like in their feet, just like your adult diabetics do. So that's why you would want to teach the good foot care. Avoid crossing legs or sitting for prolonged periods of time, just like your adult diabetics. Signs of your hypo and your hyperglycemia, which we'll cover in just a second. When you teach them nutrition, teach that they want to eat similar types of food each day at regular intervals, and they do not want to skip meals. If they're going to exercise, they want to eat a snack 30 minutes prior. If they're going to have change in activities, they may need a change in their insulin, so they want to contact their healthcare provider if they're having a change in their activities so they can evaluate their insulin. What about sick day rules? Continue their insulin. Do not stop their insulin. So some people think, well, if they're sick and they're not eating, they may want to stop their insulin, but your body's under stress, so they still require that. So monitor blood sugar Q3 hours, continue their insulin, encourage hydration, test urine for ketones Q3 hours, and encourage lots of rest. This chart is actually out of the other textbook that we used to use. ATI actually defines hypoglycemia in children as less than 60. And here is your hypoglycemia versus hyperglycemia. Small for you to read here, but your symptoms for hypoglycemia: hunger, lethargy, sensory changes, pallor, sweating, seizures, and coma. Hyperglycemia, it is your 3 Ps, Cosmal, am I saying that right? Cosmal, respirations, flushing, sweet breath, decreased CO2, dehydration, lowered sodium, potassium, bicarb, chloride, and phosphate levels, vomiting, abdominal pain, and coma. So the only 2 that are the same for hypo and hyperglycemia are coma.
Was there a difference in ATI as far as when it's hyperglycemia?
Differences? You mean in between
That chart and...
Oh, I don't know why. Do you see a difference?
No, I was just asking.
Oh,
Because you stated that the other one, that chart showed 70 as far as hypo, but ATI said 60.
I don't know. Is Does anybody have their ATI open to diabetes?
Yeah, it says hypoglycemia is less than 60.
Right, what about hyper?
Oh, sorry.
Greater than 250.
ATI is usually greater than.
What's it say, greater than 250?
Thank you.
For insulin injection teaching, teach how to give a sub-Q injection, rotate injection sites within one anatomical site, inject at 90-degree angle, 45-degree angle if they're skinny, and aspiration is not required. If they're mixing insulins, draw short-acting insulin first, and then long-acting insulin, and do not mix Lantus. And these are just showing your possible injection sites. DKA, I just want you to know that if hyperglycemia is not treated, that this is a risk factor. It's when blood sugars get really high. It's life-threatening if not treated. It's a blood sugar greater than 300. The ketones accumulate in blood and urine, and it breaks down the body fat. It can be caused by illness or poor management of diabetes or insufficient medications. These people are going to be pretty sick puppies until they're treated. IV fluids, they're going to be on insulin drips and in intensive care units until they're back under control. Did you all talk about this in med-surg at all? We did. Okay. And pretty much just tight control of your pediatric patients, pretty much the same as your adults. Type 2 diabetes, your pediatric patients, type 1 is diagnosed in your pediatric patients. Type 2 is you're seeing more of that diagnosed in your pediatric patients because of the obesity rates being seen more in pediatric patients. But it's more diet related is the reason we're talking about it now, unfortunately, in peds. Again, it's separate from type 1. It's not insulin dependent. It is preventable. Education is key. Diet and exercise is the treatment of choice. And hopefully, with diet and exercise, these kiddos hopefully will not be on medication or will get off their medication eventually. This goes over the differences. You can see the average age of onset for type 1 is 5 to 7 years. In type 2, it says 40 to 65 years is average age of onset. And this book, I'm going to guess, was probably published, this chart came out of was probably published in 2010. So I'd say that's probably decreased slightly since then. Hypothyroidism. Didn't get too far in depth, and you can tell if you've printed the notes off from Blackboard. It can be diagnosed with a newborn screen that's done in the hospital before the newborn goes home. And if it's caught early enough, then they know to treat it and prevent problems, and it's treated with the same medication that your adults take, and prevents problems with the newborn. I don't even know if this is in your ATI book. It is in Pearson, and I put the page number on your notes. Just know you can diagnose it with your newborn screen, and it's treated with medication. Early puberty. This, I will say, isn't in your ATI book. I bet when ATI comes out with their new editions next year that it is. It's in Pearson on page 1531. And it's also a new requirement from our statewide requirement list when our instructors get our required list that we have to teach. It's a secondary sex characteristics prior to 8 years of age in girls and prior to 9 years of age in boys. This is usually not an idiopathic problem, so it usually has a cause, and that is usually an external source such as anabolic steroids or estrogen. Other causes can be tumors of the ovary, adrenal gland, pituitary gland, or a genetic condition called McCune-Albright syndrome. You can see advanced bone age, unusually tall for age, and mood swings. They will draw serum LH, FSH, testosterone, and estrogen levels. If it is caused from a tumor, they may have to be removed. They may need radiation and chemo to treat that. And whatever treatment they get, if there is a cause identified that needs treatment, then they get that treatment until the average age of onset of the normal puberty. Then they would usually stop that treatment. Where do you think they think most of this is coming from? Food. Yeah, you hear about the cows and the chickens being fed these hormones and stuff that's making them bigger, bulkier, faster, and the kids are getting fed this stuff, and then that's how they're developing quicker. So, we'll see. A lot to be learned about this and being developed, and it'll be interesting over the next 20 or 30 years, I'd say. This is an article about the same thing. If it's a topic that interests you, you can click on it and read it. It's a pretty interesting article. Nurses reinforcing teaching about clinical manifestations of hypoglycemia with an adolescent who has diabetes. Which of the following should be included when the nurse reinforces the teaching? Unless you have a photographic memory. Type O, B, D, and E, so we'll go back. Hunger, irritability, and sweating. Your exam today had some questions directly from your PowerPoint. You all recognize that? Yes. All right. Moving on. Musculoskeletal. So I tried to divide these up a little bit. Some of the neuromusculoskeletal disorders will be under neuro in one of the textbooks, and under neuromusculoskeletal in another textbook. And so just bear with me. So I'm going to try to get through neuro today also, so we can just do a final review next week. So it should all be grouped together anyway. So it'll make more sense when we get through it, but so just ignore me right now. All right, so the musculoskeletal system, basically, I'm going to talk about the differences for just briefly children. So increases in the length of the long bones occur at the cartilage segment or the epiphyseal plate, if I'm pronouncing that correctly. Injury to this area in a growing child is serious because it may halt growth, stimulate abnormal growth, or cause erratic growth. Long bone growth continues until approximately age 20. Lauren, yours just completed. Congratulations. Long bones of children are porous and less dense, so they can bend, buckle, or break as a result of a simple fall. Rapid bone growth of childhood facilitates healing after fractures in children, so they heal much more quickly than adults do. Muscles, all of the muscles are there at birth. They only increase in length and circumference as a child grows. Fractures. It's the most common childhood injury, as we know. Children do all kinds of crazy things. They hill hop and drive 100 going up the interstate and do all that. We said bones will bend rather than break in children. We're talking about fractures. It may not break all the way through, though, so it may just kind of have a little, what do we call that? It's on the next slide. There you go. Epiphyseal lines may cushion blow so that the bone does not break, but it may have just a little, I want to say tear, but that'd be muscle. We'll get there. And again, healing is rapid in children. Remember, if a scan reveals a previous fracture that's in various stages of healing, it could be a sign of abuse. So always keep that in the back of your mind. Assessment, you may notice deformity, edema, pain, warm redness, ecchymosis or crepitus over a site of a fracture. It's diagnosed by x-ray. And treatment obviously depends on the type of fracture. Care, your priority obviously is going to be your ABCs. You want to make sure they have patent airway. Stabilize your patient, make sure they're breathing. Vital signs, make sure they're stable. Address their pain. Assess their neural status. And whatever extremity is affected, assess the neural status of that extremity. So how are you going to do that?
Every pulse.
Okay, check the pulse. Can you feel this? Look at the color, the temperature, edema, very good. Capillary refill. Let's see. Position the client supine, stabilize the area, elevate and apply ice, and keep the client warm. Here's the types of fractures. So the first one's the bend that we were talking about that children can do easily because of their bones. And the buckle. The green stick, that's the one that it's not going all the way through. That's what I was trying to think of. The complete fracture and the hinge one at the bottom doesn't go all the way through. Treatment can be casting, traction, or surgery, depending upon where it's at. You want to watch for, and we'll mention this several times, compartment syndrome, which is nerves, vessels, muscles becoming compressed, which can lead to necrosis. You'll see this a lot of times with casting. We'll talk a little bit more about. They're unable to move anything past the casting or the traction. The extremity's pale, there's no pulse. Distal to the fracture, there's numbness, there's increase in pain, unrelieved with medication or elevation. Cast care. There's two different kinds of cast. What kinds?
Fiberglass.
There you go. Plaster cast and fiberglass. Plaster casts are heavy, they're not water resistant, and they take 10 to 72 hours to dry. Fiberglass are light, they're water resistant, and dry in 5 to 20 minutes. Which do you think are preferable? Especially in children, okay? Here, 2-year-old, stay still while there's a heavy, non-water resistant cast that takes 10 to 72 hours to dry. Okay, not too fun, right? Prior to having a cast applied, you want to observe the skin integrity of the child, make sure it's clean and dry, pat any bony areas to prevent breakdown, and you may want to show the procedure on a doll so they know what to expect, and assess neurovascular status. Children need explanation of what to expect. When the cast is being applied, it will begin to generate heat that will subside, and it will not burn the child. So you want to tell them to expect the heat, because they may get freaked out and may think that it's burning them. After the cast is applied, you want to elevate the cast above the level of the heart for 24 to 48 hours. This is to prevent swelling. Apply ice for 24 hours to decrease swelling. Turn and reposition every 2 hours to allow drying. Do they want to use hair dryers or heat lamps to help this?
Yeah,
Yep. She said don't use forks to scratch anything that itches underneath that. Bad idea. Support extremity with sling or elevate when sitting. You want to assess the temperature of the extremity for heat, and this is to assess for infection. If there's a wound present, this can be monitored through what we call a window in the cast, and this is the kind of an opening that they'll leave so you can monitor that wound. Assess for drainage. You can cover areas of cast with plastic to prevent soiling. You want to tell the client to report pain lasting greater than 1 hour that's not relieved by pain meds. You want to teach them how to do neurovascular checks. They're going to have this cast and you're going to send them home. So if their fingers get blue, if they can't feel anything, if they can't move them, if their pulses go away, they're going to want to report that. We're going to tell them not to place foreign objects inside the cast, like the fork or the G.I. Joe when they go home. The compartment syndrome, it can occur when a cast is too tight or constricted. And they need to report this immediately. When the cast is removed, they are removed using an electric cast cutter with a rapid vibrating circular disc. This can be scary for a child. So support is needed and reassurance that the saw will not cut them. And their skin will look dirty afterwards. Instruct to soak the extremity in warm water and apply lotion. This just talks about like the adjustment of crutches, fit and adjustment. Crutches can be prescribed for one of 3 reasons: to keep weight off of one or both legs, to support weakened legs, or to maintain balance. They should be 1 to 1.5 inches between the axilla crutch pad and the child's axilla to prevent compression and damage of the brachial nerve. Walk with the crutches placed about 6 inches to the side of the foot and educate the child on this. Traction. type used depends on the type of fracture, age of the client, and associated injuries. I'm not sure what this video consists of. Let's see. Or maybe it's a picture. Because I'm on the internet. Okay. All right. I don't know what that is. All right, skin traction is a pulling force applied by weights. You may have heard of it as a buck traction, Russell traction, or a Bryant traction. Skeletal traction is continuous pulling force applied directly to skeletal structure. A pin or a rod is inserted through bone and force applied by weights. Balance suspension traction suspends leg in flexed position. Hip and hamstring muscles are relaxed. And what you see here is a halo. Cervical traction encircles the head. Screws in outer skull attached to bed traction or rods that are secured to a vest worn by a client. Anybody ever been in any sort of traction? You have? Was it painful?
Yeah, I was 9.
Yeah.
I had the hip one, or the balance one.
I've never known anybody in it. I've taken care of patients in traction before, but it looks very painful. I've transported patients after surgery, after like a hip surgery or a knee surgery, in traction with the weights off of the end of the bed, and I've had transporters like drop the weights. Yeah, so that's something you want to be real careful to monitor, make sure those weights don't get dropped. Also, the pin sites you want to monitor for infection, make sure they stay cleaned appropriately. I've never taken care or I've seen people, but in the halo traction, but it looks very painful. As far as nursing action, same as cast care, as far as education and care of the client, but you also want to maintain body alignment. Monitor for muscle spasms, pin care, which we just talked about. Make sure the hardware stays tight and that the bed is in the correct position. Assess and maintain weights. If it's a halo vest, you want to assure the wrench is attached to the vest in case the CPR is needed. So if this client has this vest on and you have to do CPR, you want to make sure you need to get that vest off, right? So there's a wrench on there somewhere that you need to make sure is attached. There's an overbed trapeze, deep breathing, and incentive spirometer on these patients, hydration and nutrition. Osteomyelitis is infection of the bone. Speaking of differences in pediatrics and your adult patients, if the epiphyseal plate become infected for the children, then altered bone growth can result. Obviously, treatment is going to be, what do you think? Antibiotics. Also, limitation on weight bearing on affected area, bed rest, immobilization, IV diet high in calcium and protein, and pain management.
Is that likely due to trauma?
It can be related to trauma, fractures, especially open fractures. I was reading something, trauma, and I was seeing if it was on my notes, but I don't see it.
IOs will do it.
What'd you say?
A not clean site, when you're putting in an IO, will do it. The intraosseous lines.
Oh, absolutely, yeah. An IO from not being clean. Congenital musculoskeletal. Clubfoot. Going back to the newborn a little bit here. This is most of the time diagnosed prenatally. If you have someone that's doing their regular prenatal care, it can be identified on the prenatal ultrasound. It's a deformity of the ankle and foot. It can be unilateral or bilateral. It's got various different terminology based upon if it's eversion, dorsiflexion, plantar flexion, all that good stuff. It's on your notes. And I'm not good at pronouncing, so I'm not going to read them to you. Nursing care is going to be supporting the parents. Some of this, its official diagnosis is done by ultrasound because sometimes babies are born and based upon how they were in utero, the foot may just come out and may be just crooked for a few days because the baby was kind of crunched up in mom, and after a few days it'll straighten back out. But by ultrasound they can actually diagnose it as an actual clubfoot. You want to support the parents, encourage them to hold and cuddle the infant to enhance that bonding. You want to educate on how to meet the infant's developmental needs until this is corrected. So we'll talk about in just a second casting. So eventually they will cast this leg. So when the infant starts to crawl and all that good stuff, how can the parents best meet the developmental needs of that child? And also teach the parents how to perform neurovascular and skin integrity checks on these kiddos. Treatment, like I said, they're going to cast these kiddos. It's a series of casts that start shortly after birth and continue until the correction is achieved. It's a long cast, so some people think it's just going to go like right above the ankle of the child, and actually the cast goes all the way up to the top portion of the leg. So think about it. If you have a cast that's the full length of the legs, what do babies do a lot of? Poop and pee, right? They do a lot of the other stuff too, cry. I get it. But we're worried about skin integrity there too. So cleanliness is an issue with those casts. So it goes all the way up the legs.
And he gave himself hernia because he was trying so hard to take his legs away from the cast.
I mean, they're pretty big casts too. They're not like anything small or you would think with. It goes all the way up the leg. So you're concerned with soiling and skin integrity with these. So complications could be growth and developmental delays, skin breakdown, and neurovascular alterations. Legg-Calve-Perthes disease. Somebody pronounce it for me if you know how to. Okay, there we go. Aseptic necrosis of the femoral head. It can be bilateral or unilateral. It's usually unilateral. Risk factors include trauma or coagulation defects. Assessment, you will see an intermittent, painless limp, hip stiffness, limited range of motion, pain in thigh, shortening of affected leg, and muscle wasting. Diagnosis is made by x-ray. Treatment varies with age and appearance of the femoral hip. You may give NSAIDs. They may encourage bed rest, non-weight bearing. Do an abduction brace, cast, leather harness sling, traction, and then advance to active motion as prescribed. Or they may need a surgical total hip resurfacing or a total joint replacement. Anybody familiar with this disease? You are?
My cousin was it.
Really?
And my grandpa had it. My grandpa actually was on crutches for like 10 years of his life when he was younger.
Who was the other one that had
And
it?
then my cousin was on it for two and a half years of crutches after he was diagnosed with it. Couldn't put any weight on it, like,
No surgery?
he didn't have surgery, but they like monitor it and like when he was younger, like it like almost like came out of place. And then so they put it back, but he still limps to this day. Or, you know, he still limps, like couldn't play sports when he was little. The only thing he did was play golf. And he went to college.
I've never heard of it until it showed up on my required list to cover.
It's like painless limp. Like he's like, I don't have any pain, just a limp.
Really? You come as a guest speaker. Maybe he could help me pronounce it.
Yeah, I don't know. When I saw the last of parentheses, I'm like, yeah, that's it.
All right, something that I haven't seen before. Hip dysplasia. Developmental hip dysplasia. It is risk can be from birth order, family history, intrauterine position, delivery type, or joint stability. Assessment in infants, you'll see asymmetry of gluteal and thigh folds. I'm going to flip through because I think I have a picture. No, sorry. Thought I did. So the gluteal fold, so if you hold an infant up and you look at the back of their thighs, like you'll see one thigh may have here's their legs, here's their butt.
We can't see that.
Can you see that?
No.
Okay.
It's just their upper thigh has these like.
Has more
maybe
fat
three on
rows
one side or one-
than the other. So if one thigh has more fat rows than the other, then you may suspect it. Also, if any of y'all have been in the nursery and saw a pediatrician or a nurse checking for a hip click, they're checking for developmental hip dysplasia. Okay? Limited hip abduction and shortening of the femur. A positive, and excuse my pronunciation, Ortolani test. And this is when abduction causes the hip reduction, or a positive Barlow test, which is adduction of the hip, dislocates it. And this is when you hear the, or feel the click when they adduct the hip. In a child, they'll have a shortened leg. They'll walk on toes on one foot, walk with a limp. And most likely they've caught it by this point. It's diagnosed by x-ray. If their foremans are older, and ultrasound in infants. Care, newborns to 6 months, they'll do a Pavlik harness. can do, I'm sorry, I was confused on the notes, so I'm reading them. I'll pause for a second. They can do a Pavlik harness, Bryant traction, or a hip spica cast. I'm going to show you pictures. So the Bryant traction is on the left. The hip spica cast is down here on your right, and the Pavlik harness is on the top right. Okay. So the Pavlik harness you can remove, but you can put it right back on. Okay. So hopefully that would be the treatment of choice. Okay. Because these other, the hip spica cast doesn't come off. It only comes off for them to adjust it for growth, and they put another cast right back on. Okay, so we say that newborns, we're talking newborns to 6 months of age, do a lot of pooping and peeing, so we're really worried about skin integrity, right? Hip spica cast, so we're down here in the bottom right-hand corner, change to accommodate growth. Again, skin care we're worried about. You want to position on pillows, sponge baths, because you don't want to get this cast wet. If they're 6 months to 2 years of age, they're going to do surgery and then apply a spica cast. And older children are going to do a surgical reduction with pre-surgical traction, which is what you see kind of on the left there. All right, everybody's kind of familiar with scoliosis, kind of. Everybody's been screened for it, right? At some point, maybe. Now, I do know this link is to the ATI website. It goes over a screening for scoliosis, and I just tried to log on, it wouldn't let me, so you all have access to that. So if you remember being screened yourself, you probably remember they have you either put on a bathing suit or put on something that they can see your back and have you bend over and see if it's crooked. Most of the time, what age were you? About? Yeah, middle school, upper elementary school. And that's usually routinely when they screen you for that. It's a complex deformity of the spine. It affects ribs, lateral curvature of the spine. Curve of at least 10 degrees for diagnosis. There's a genetic tendency. Assessment, you'll see asymmetry in the ribs, shoulders, hips, scapula. One leg is shorter than the other. And improper fitting of the clothing. Diagnosis, again, screening pre-adolescence. Have them bend over at the waist with the arms hanging down and observe in, your textbook says underwear only. Maybe a little bit more conservative than that. If it's suspicious of scoliosis, then they will do x-rays to determine the degree of curvature, and treatment will depend on the degree, location, and type of curve. What do you think we do for treatment? Most likely bracing, 23 hours a day, which is very rough. Yeah. You want to assess the skin. You want to have them wear a thin, usually tank top or something underneath to protect that skin. And this is for a slow curvature. If surgery is required, it's greater than 45-degree curvature. It's usually an ICU hospital stay. It's a major surgery, but with the advances today, they usually do pretty well with it. They should expect an NG tube, post-op catheter, PCA pump to be log road because it's spinal surgery. Complications from scoliosis, they could have breathing difficulties because it could inhibit their ability to expand their lungs. They could have low self-esteem. Low self-esteem because they could be different. I mean, just, they could be crooked, or they could be wearing a brace. You have a kid wearing a brace. Infection from surgery, spine and nerve damage if left untreated. So most of the time we routinely screen to prevent complications, pre-adolescence, middle school, late elementary school. And a personal story, so my niece was 5, and we were at the 4-H fair. She had her animals there, and she had on her tank top, and I see my niece pretty much every day. And she had on a tank top one day, and I just looked at her, and I looked at my sister, and I was like, she's crooked. And it was like major, major crooked. She has really bad scoliosis. And you can't see it, and I wish I'd have gotten a better picture, but she used to come to Sim Lab for our PED Sim. I couldn't figure out how to get the picture turned. But this is her brace. She's usually not this happy when she has it on. Just to tell you, we can't get her to wear it. So this is her second one, because they obviously make new ones every time they grow. So they prescribe it. They start out wearing it an hour a day, and then 2 hours a day, and then 3 hours a day, all the way up to 23 hours a day, which she doesn't do. You can't get her to do it. Like, she'll probably end up having to have surgery, they said, but I mean, anyway, she's got really bad scoliosis. But I don't know if you can see, it's on the left side. Can you see her spine on the left side of her body there? But that's pretty uncomfortable, and in the summertime, it's hot. It's a really thick brace, and you can see it in the background there too. She has to wear a top underneath the brace too, so. Questions about scoliosis? I got a few more slides. This is where some of these neuromuscular disorders you'll see in some neuro chapters elsewhere. Okay, so just bear with me. It may kind of cross over into some other disorders, but we'll just, so CP. It is a non-progressive impairment of motor function, muscle control, coordination, and posture. An abnormal perception of sensation, and it is different for each child. So risk factors for CP are anoxia to the brain, choreo, and do you all remember what choreo is?
Infection of the spinal cord.
Infection of the amniotic fluid in utero. Premature birth, multiple births, low birth weight, placental dysfunction, kernicterus, do you all remember what that is? High bilirubin level, and not enough oxygen during birth. Assessment, failure to meet milestones, persistent reflexes such as a Moro reflex and tonic neck reflex, poor suck reflex, tongue thrust, poor head control, abnormal posture, asymmetrical crawl, seizures,
Farm has a mind of its own.
There's different types. They're listed on page 323 in your ATI book. Spastic, dyskinetic, and ataxic. Actually, I'm gonna let you all take a break because we'll click on this video. I think it's about 10 minutes. That's okay. 5-minute break.
Yeah, and then, I was like, matter of fact, I'm not gonna